Hi everyone, this is our third and final lecture for Unit 2. This lecture will be on promoting healing, specifically wound closures, devices, and dressings. Later on in this lecture, we'll also talk about drains. One of the most common types of wound closure devices are sutures or staples. These are typically made of nylon, silk, or metal, and they're used to sew the body tissues together. So this is either for primary intention healing or possibly a tertiary intention healing. It does help reduce the scar formation, also controls bleeding. There are multiple different types of suturing methods, such as intermittent, continuous, blanket sutures, or retention. So it is your responsibility to know which kind of sutures the patient does have. This photo here is a photo depiction of the intermittent type of sutures. There are also superficial or deep. Superficial sutures tend to be non-absorbable, and they do need to be removed. Sutures and staples are considered to be foreign bodies, and they can cause some local inflammation. So if you look on this photo here, you can see a little bit of redness around these knots of the sutures. Those are the local inflammation. So that is a normal response. Normal to see a little bit of redness. But if we see that redness expanding, but a little bit greater than approximately 2 millimeters, then we're going to start wondering and start assessing a little bit more, because potentially there is a different indication for that inflammation, such as infection. Once the sutures and staples have completed their task or completed their job, and the wound has started to heal closed on its own, it is our responsibility as a nurse to remove them. Typically, sutures or staples can be removed 7 to 10 days post-insertion, but I have seen them removed up to 14 days. It's just dependent on the patient and their risk factors for wound healing. So in order to remove them, we need to make sure that we can remove them. As previously stated, there are multiple different kinds of sutures. The nursing can only remove certain kinds of sutures and the kind of sutures that they actually know how to remove. So if it's a continuous suture, they involve a little bit more knowledge for how to remove them than just a plain intermittent suture. So we're going to mostly just focus on the removal of the intermittent suture today. We're going to check with the doctor's orders. We're going to assess the incision site. We're going to make sure that it is appropriate for these sutures to be removed. So we're going to make sure that this incision looks to be healed, that the edges are well approximated, meaning that they are closed and touching each other, and there's no sign of infection or any dehiscence. We'll talk about dehiscence later on. We're going to remove all of the sutures or alternating. So this is dependent on the physician's orders. So typically the physician's order to either remove all of them or alternating. If they order to remove alternating, we will remove every second suture. Then typically we go back 24 hours later and then remove the remaining sutures. When it is time to remove the suture, we want to take our scissors and snip as close to the skin as possible. So then we pull that suture, or the amount of suture that we pull through the skin decreases the chance of infection. We don't want to cut the suture line above the skin, because then the suture that is sticking out of the skin is then going to be dragged underneath the skin and then through, which increases the patient's risk for infection. So trying to snip as close to the skin as possible just decreases that infection risk. After we remove the sutures, we typically apply steri-strips and put a small dressing on the wound, just as a reinforcement. We'll talk about steri-strip applications as well. Steri-strip application. So this is something that you are going to cover in lab. You will cover it at the same time that you cover suture and staple removals. So steri-strips are small little pieces of a low tension dressing, and it is used to apply tension onto the wound to decrease the risk of dehiscence. It reinforces the skin integrity after suture or staple removal, or can be used with sutures and staples. They're typically breathable, and they do come in a sterile package, so they are considered to be sterile. They cause very little tissue trauma, and they are to be left in place until they naturally fall off. So steri strips are not to be removed by force. They are to be allowed to fall off on their own. If we remove them with our force, we are causing extra stress to that wound, which then can potentially cause some alterations to it or some complications. So we just let these steri strips naturally fall off on their own. Okay, so now we're going to jump into dressing application. So this is a very standardized application of dressings. So in order to apply a dressing to a patient, typically they are ordered by a physician. Specific dressings will be requested by a physician, and it is our responsibility as a nurse to note if that dressing is appropriate for that patient. So we not only need to learn about the different kinds of wounds that our patients can have, but we need to learn about the different kinds of dressings that we can apply to those wounds and know if they are appropriate for this to promote which kind of healing environment. The purpose of the dressings are to decrease the risk of infection and keeping those wounds dry or clean and moist. So these dressings, the majority of the dressings are sterile. So we need to make sure that we are maintaining sterility as we apply them. We need to ensure that these dressings have a nice smooth adhesive surface, as any holes or wrinkles can provide a path for microorganisms to get into the wound. We can use some non-adhesive wrap, which is what this is here. This is called cling wrap. For wounds or for skin or tissue that tends to be a little bit more fragile and has a higher risk of skin tears. These non-adhesive skin wrap dressings can also be used for patients who have adhesive allergies. The first specific type of dressing we're going to talk about is probably the most common, which is gauze. So gauze is typically used in adjunction to a cleaner to clean wounds, but it can also be used as a dressing. Historically, gauze was our go-to dressing type, but it is no longer our standard run-of-the-mill dressing. Advancements have come a long way in the development of dressings, so gauze is no longer the most appropriate type of dressing to choose from. Gauze is now typically used more for cleansing and cleaning wounds, but it can still be seen and used as a dressing type. So gauze is used over top of a simple wound, and it is placed dry. Gauze does have a minimal absorption, so these wounds that it is appropriate for are low exudating wounds. It comes in multiple different sizes and shapes. It comes in 2x2s, 3x3s, 4x4s. This here is a 4x4. This is a gauze sponge, or a drain sponge, sorry. So it has a slit, or it can be slid around a drain. And then we have tubular gauze as well here. So it comes in multiple different shapes and forms. It is non-adhesive, so it does require extra adhesive tape or dressings to secure it to the patient. It can be used as a packing material. We'll talk about wound packing later on as well, if it's moistened first. So non-adherent dressings. So these are dressings that do not cause damage to the tissue layer underneath them. So these dressings, there's two different kinds that are most common. The first one is a non-adherent contact layer. So this dressing is made of a tool and is infused with either petroleum or silicone. These are then placed on top of the wound and the peri-wound, which then remains the skin, which allows the skin to remain intact underneath. It allows moisture to pass through it, but it does require an absorbent top layer, as this dressing itself does not absorb anything. It's just a barrier or protection between the dressing and the patient's skin. The next one we have is a soft silicone dressing. So this one is a little bit more of a honeycomb or a mesh-like texture. This one here is a soft silicone dressing. These tend to float above the surface, so they have they are hydrophobic, meaning that they repel or they sit right above the water or right above the patient's skin. So that's the float above. They do not interfere with any wound healing, as it actually doesn't technically touch the wound, as it just floats right above. They can be used on fungating wounds or wounds with very fragile skin. But they do also require an absorbent over top layer. So these wounds or these dressings as well, similar to the non-adherent contact layer, do not have any absorption mechanism, so they do require an external layer over top. Next, we have hydrocolloid dressings. So hydrocolloid dressings are used on wounds with minimal drainage and no evidence of infection. These wounds can have slough on the wound base. So if you remember in section 2 of 3 for this unit 2, we talked about slough or the yellow wound base. So these hydrocolloid dressings are appropriate for wounds that have a yellow base. They can be used for both shallow and deep wounds. They do provide something called autolytic debridement, which we'll talk about the different debridement agents and the different debridement forms later on as well. They tend to liquefy the slough, so it breaks down that slough formation and liquefies it, which then makes it easier to remove. It doesn't affect the healthy skin. It is adhesive itself, so it does not require an external adhesive to have this dressing stick, and it is occlusive, so it does not allow any fluid or anything to penetrate this dressing. And they can be left on for 5 to 7 days. We just need to be a little bit cautious with these dressings, as when they do absorb some drainage, the drainage itself can be made to look kind of like a purulent drainage. It's just because of what this dressing is made out of. When it does get moistened, it does turn into a purulent-like residue, which is why we need to be very careful when using this with a patient with infection. And we need to have our assessment skills on par as we're looking for other signs and symptoms of infection other than just that presence of the pus, because that pus may not actually be a purulent drainage. It might just be the exudate from the wound or from the dressing itself. Nextly, we have the transparent film dressing. So these are commonly used to secure our IVs. So they're these clear little dressings that are secured over top. Commonly, these are called tegaderm dressings. They provide an occlusive barrier, so nothing can penetrate through it. They are self-adhesive, so they do not require an external dressing or an external adhesive event, but they can be difficult to remove. So we are not to use them on fragile skin. I have seen in numerous incidents that a tegaderm, when removed, it has actually caused a skin tear in the exact dressing shape. So just be very mindful of the type of patients that you are putting these on, that they do not have any of the risk factors for developing a skin tear, as discussed in one of the previous groups of this unit, previous lectures of this unit, sorry. To remove them, we want to grab an external corner of this dressing and then we pull it parallel with the skin. This causes the adhesive to break, but not cause any trauma or any pressure on the skin itself. If we were to take this dressing and lift it up and then pull it backwards, like we would normally take off just a regular bandage, we would cause some extra trauma to the skin, which then can lead to those skin tears. So transparent film dressings are used for non-exudating wounds, so wounds with no drainage. Foam dressing. So foam dressings can either be adhesive or not adhesive. So these two photos here are pictures of foam dressings with adhesive. So if you look, you can see the inside of the dressing here. This is made of a foam, and then the outside of this dressing is the adhesive layer that is attached to the foam, which is then applied to the patient's skin and secured. They come in a multitude of different sizes and shapes. There are ones that are specifically made for certain areas of the bodies as well. They absorb a moderate to a large amount of exudate, so they can absorb a fair bit of exudate, and they can be left in place for up to 7 days. They help the peri-wound skin heal by wicking the moisture away from the healthy skin. These are very common dressings, and we do commonly see them on pressure ulcers on stage 2 and stage 3. Next, we have a negative pressure wound therapy. So these are our wound vacs, which you may have heard of them. They provide negative pressure therapy to promote wound healing, meaning this external vacuum device is hooked up to the patient's wound to then increase blood flow to the wound base. So these negative pressure wound therapy, they do require advanced training to apply them, but this is something that you may receive if you work on a unit that often uses negative pressure wound therapy. So there is a sponge that is placed inside of the wound itself, and then it's hooked up to this vacuum with an occlusive barrier around it. So when this vacuum is activated, it pulls through that sponge and to the wound base, which then causes blood to flow to that wound base, which then promotes healing. It also allows for all the exudate to collect in this little reservoir. So then it keeps that wound base moist, but not wet, which then promotes healing. They are quite expensive, and as stated, they do require further education on application. Okay, so wound packing. So I previously did mention wound packing when we did talk about gauze. You can use gauze for a form of wound packing, but most often we will see wound packing ordered by the physician with some sort of antimicrobial or antibiotic built into that dressing. So this wound dressing here, this type of dressing, is called iodoform. So it's a specialized infusion of the dressing itself to help that wound heal. So wound packing is to be completed after the size, depth, and shape of the assessment has been completed. So these are for more complex wounds, more chronic wounds. So packing is not required if less than 5 centimeters of the packing is needed. As previously stated, the physician will order the type and material of the packing used. The packing material must be moistened prior to it being packed. If we don't moisten this packing material prior to packing the wound, we then create a dry wound base or a dry environment for this wound, which then does not promote wound healing. So if we moisten this dressing prior to inserting it into the wound, we keep that moist wound environment. And typically the fluid that we use to moisten the wound is normal saline. But some physicians may order a different kind of solution. So how do we pack the wound? There are a couple different techniques. You will go over this technique in lab as well for how to specifically pack the wound. So we need to make sure that the entire wound surface touches a part of the moist packing, that we do not create a hole or not pack a certain area of the wound. The wound packing cannot touch the patient's peri-wound or the surrounding skin, because we want to keep that peri-wound dry. We want to keep that intact. We do not want that to be moist and to further break down. So healthy skin, we want dry. Healing skin, we want moist. We can loosely pack or insert this packing into any undermining or any tunneling. So any wound bases that protrude underneath the skin. So undermining and tunneling. We want to ensure that we do not pack too tightly. So we do not want to create a ball inside the patient. We want to just lightly pack this wound packing in to just fill the cavity. And we need to document the amount of packing that we placed in the wound so we can accurately assess when we go to remove it the next day if all of the wound packing that we placed in did come out, because we do not want to leave any packing inside the patient. So this photo here is not the best depiction of how to pack a wound, as they have the wound packing sitting on the peri wound here. So ideally, you don't want the wound packing at any time to touch the peri wound, as that would contaminate the wound packing. So we want to keep the wound packing as sterile as possible. So we would want to keep it or hold it into a gloved, sterile hand as we pack it into the wound. But other than this little area here, it is a good depiction of how to pack a wound. So we're going to be putting the packing inside a wound, so it covers the full base of the wound, and then extends a little bit over top, but does not overhang onto any of the peri wound. So we do not want the wound or the packing just to sit on top of the wound and then not go into the base. So what happens if we just have packing on top of the wound and not into the base? This wound is going to try and heal by primary intention. The dermis of the skin is going to heal faster than the underneath area. So what's going to happen is this area is going to close, and then we're going to be left with an abscess underneath. Which then this abscess is going to grow, it will likely become infected, and then when it does open, or the wound itself is going to be 2 to 3 times as big as it was initially. So if we put the packing inside the base of the wound, then we encourage healing through secondary intention. So healing of the wound from the base up. So we're keeping the top layer of skin open so the wound can appropriately heal without the formation of an abscess. There are 5 different kinds of debridement that we do commonly see. The first kind of debridement that we see is surgical debridement. So this is done by a physician, typically a surgeon, or it can be done by an advanced practice nurse as well. Surgical debridement is completed by cutting off of the necrotic tissue to expose the underlying viable tissues. This can be completed in an OR or it can be done on bedside. It's just dependent on the size of the wound and the size of the necrotic tissue that does need to be removed. Next, we have mechanical debridement. So this is the forceful removal of any unwanted tissue or debris through ripping it off with a gauze or high pressure irrigation. So this is non-specific, so it does damage both healthy tissue and unhealthy non-viable tissue, and it can be quite painful. So mechanical debridement is something that typically happens on accident. It is something that is not done on purpose. So mechanical debridement through ripping off with gauze is probably the most common kind. So this happens when a dressing gets dry or the wound gets dry and the dressing adheres to the wound itself. And when we go to remove the dressing, it causes, it sticks to that wound base and then rips off both that non-viable and that healthy tissue. I like to think of mechanical debridement as picking at a scab. If we pick at a scab, we both remove the non-viable, the unhealthy tissue, that scab, and then it causes a little bit of damage to that healthy tissue underneath. And this can be quite painful. So to try and discourage or to prevent mechanical debridement on any sort of dressings that are stuck to a patient, we don't just want to rip them off. We may want to soak them with a little bit of normal saline first to try and ease that removal off without forceful. Autolytic debridement. So this is use of a specialized dressing. So keyword here being dressing, to remove or to promote softening of dry, non-viable tissue. So we had previously talked about a hydrocolloid. So hydrocolloid dressings promote autolytic debridement. So these are typically quite painless, but they cannot be used in infected wounds. And we have enzymatic debridement. So very similar to autolytic debridement, but it is a topical ointment that is applied directly to a necrotic tissue. This enzymatic debridement must then be covered with an external kind of dressing. And lastly, we have biosurgical debridement. So this is the use of maggots. These maggots then eat the dead tissue, but they leave the healthy viable tissue alone. So maggots are actually a great use, or a very great or very effective use for debridement. They're not seen in Canada very much, but they are quite common in other cultures and other countries. So one of the most common dressings that we use to promote debridement is called a hydrogel dressing. So this dressing promotes the wound environment as it promotes some autolytic debridement, and it can be used on necrotic tissue, but it cannot be used on any draining wounds. So this dressing itself needs to be placed right against that necrotic tissue in order to work. It commonly comes as a dressing, but it can also come as a gel form. So this here, there's some gel in this little tip of this little canister, and then it is squirted out through this funnel directly into the wound base. Or it can come as these little dressing types here. They both need to have a dry gauze or Teflon over top to secure it in place. The last kind of dressing we're going to talk about is alginate and hydrofiber dressings. Alginate is a manufactured type of dressing, and it is manufactured from seaweed, which then allows a moderate to a very large amount of exudate to be absorbed into this wound dressing itself without a lot of bulk. It's used for both partial and full thickness wounds and can be used for infected wounds. These cannot be used on dry wounds, as it does suck up all the moisture from that wound into the dressing itself. So it does need to have some sort of exudate in order to be effective and to promote proper wound healing. They can be used with an antimicrobial medication such as silver. So I have two photos here. This one, Aquasol Extra, it's just the regular hydrofiber dressing, whereas we have Aquasol AG. So AG is the abbreviation for silver. So Aquasol AG is the hydrofiber dressing that is infused with silver, and it does state that here right on the box. Hydrofiber dressing with silver and strengthening fiber. So they can be placed under different kinds of dressings, such as gauze, and they can be packed into wounds as well. So these dressings are typically cut to fit right into the wound base, so it is not touching the dry peri wound, as we don't want it to be on the dry wound. We just want it to be into the wound base, or it comes in a ribbon that can be packed into wounds. Okay, so what are some complications of wound healing? There's multiple complications that we are trying to prevent, and we need to know how to treat. So the first complication is hemorrhage. So this can occur immediately post-operatively or post-injury, and it may need a pressure dressing. The patient is at greatest risk for 24 to 48 hours post-trauma for a hemorrhage. Obvious signs are distension or swelling, bleeding, changes in the amount of drainage on that wound, or signs of hypovolemic shock. If you guys don't remember what the signs of hypovolemic shock are, I encourage you to go back to your pathology and review the signs and symptoms of hypovolemic shock. So as a nurse, what are we going to do if we are suspecting to have a patient who has a hemorrhage out of their wound? We're going to apply pressure if we possibly can. If it is on an external area, that we can apply that pressure. We're going to assess their blood pressure, their pulse. We're going to monitor for that hypovolemic shock, and we're going to report it as soon as possible to both the charge nurse and the physician. So the use of a pressure dressing are very specific to hemorrhage wound. So pressure dressings are a type of external dressing that is tight, that applies pressure to that wound. They can be applied in numerous different methods. For here, on this wound here, you can see pressure dressing being applied through wrapping of the dressing on there. We just need to be very cautious when we're applying that pressure dressing that we are just limiting blood flow, that we are not completely occluding blood flow. If we did apply a pressure dressing and completely occluded the blood flow, this patient would then no longer receive any blood flow to their extremities. So we need to be very cautious with our pressure dressings that we're applying the appropriate amount of dressing to slow the bleeding, but not to completely stop it. Up next, we have infection. So infection most commonly happens 48 to 72 hours after a wound, but symptoms may not be present until 5 to 7 days. So symptoms do have a delay in showing after an infection has set. So it's very important to follow the doctor's orders when dressing change is required. Most often dressing changes are not ordered within the first 48 hours of a surgical wound. This is to prevent the high risk of infection. As I stated, infections typically happen 48 to 72 hours after a wound has been formed, so that does include surgical wounds. Signs and symptoms: a fever, purulent, odorous drainage, swelling, tenderness, warmth to the peri-wound, increased pain, and increased white blood cell count. So this is their CBC count, or part of their CBC count. What are some risk factors for infection? A wound that has necrotic tissue, so a wound that doesn't have viable tissue anymore. Contaminants in or near the wound, and a reduction in the blood supply. We also have risk factors of obesity, diabetes, poor circulation, advanced age, prolonged surgery, steroid use, wound dehiscence, or evisceration, which we'll talk about on a later slide. The next wound complication is fistula. So fistula is the abnormal passage between two organs, or between an organ and the outside of the body. There are different types of fistulas, but we're not going to go through those types of fistulas. We're just going to talk about the wound care fistulas right now. So the results, a fistula does result from poor wound healing, or does it a disease complication. So it does increase the risk for infection and fluid and electrolyte imbalance. It increases the risk for skin breakdown. So in this picture here, we have a picture of a small intestine fistula, where there's a fistula in between two small intestine tracts. Or is this one here, which is the wound care fistula. So we have an abscess that has formed internally, and then it has created a canal both externally and internally. So which means that there is an opening between the outside and the inside that is not normally there. So I've previously mentioned tunneling and undermining a few times already. We're now just going to get a little bit more into depth as to what tunneling specifically is. So tunneling is the abnormal growth of the wound down into the patient's body. So here we have a tunnel that has formed going down from the wound base in towards the patient's body. Tunneling may go from one wound to another through the epidermis. It may result in the development of an abscess. So if we see this tunneling here, it is starting to get a little bit wider right here than it is at the beginning of that tunneling. So this has a high risk for an abscess formation. Whereas these ones here are a little bit narrower, so the risk of that abscess formation are a little bit lower. But they can very easily turn into an abscess or a widening of that wound or that tunnel. If a tunnel is left untreated, it can turn into something called a sinus tract, which then the walls of that tunnel are then lined with epithelial cells, which then no longer heal, can no longer heal, and then do require surgical intervention to remove those epithelial cells for that wound to heal. So a tunnel can turn into a sinus tract, which then requires surgical intervention. Next, we have undermining. So undermining again may occur from one wound to another, but it's the loss of tissue greater than the skin. So if we take a look at this photo here, we can see right here that the wound base appears to go underneath the skin. So that would be an undermining aspect. So that where the wound base extends farther than what the external skin wound is. So if you go back one slide, there's also a photo there of the undermining on the tunneling slide. and it's where the wound just right underneath the skin extends. So it indicates progressive tissue loss. So it means that that wound is not healing correctly. Those tunnels need to, or those undermining needs to be measured, and they need to ensure that they are cleansed appropriately because they do have a higher risk for infection and for an abscess formation. Wound dehiscence. This is the partial or total separation of a wound edge. It may occur after removing sutures before the doctor's order or removing all sutures at once. So this is typically why physicians order to remove alternating sutures. So remove every other suture one day, then 24 hours later going to remove the remaining sutures. Is to perform or to prevent the formation of a dehiscence. It has the highest risk of occurring 1 or 3 to 11 days post-injury. Patients who are at the greatest risk for wound dehiscence are the patients who are at risk for poor wound healing. So these are patients who have poor nutritional status, have an infection, who are obese, or who have external stressors onto that wound. So those stressors can be coughing, vomiting, just an act of sitting up using their abdominal muscles. So how do we prevent dehiscence from occurring? Is encouraging wound healing. So encouraging all those aspects to promote appropriate wound healing. Then splinting during a stressor. So using that pillow or the abdominal binder if the wound is on the abdomen when the patient coughs or when they sit up, just to apply and support that pressure. So after dehiscence, we have something called evisceration, which is considered to be a medical emergency. So this is where a protrusion of the internal organs happens through an incision. As the previous stated, it is a medical emergency. So what do we need to do as nurses? If we have a patient who has a wound that is eviscerated, we need to stay calm. We need to stay with the patient, and we need to ask another nurse to bring some sterile supplies in and to notify the physicians. We need to assist the patient into a semi-Fowler's position with their knees slightly flexed, as this eases pressure on the wound, eases a lot of stress on the abdomen. So semi-Fowler's position, knees slightly flexed. And then we need to cover the wound with a normal saline soaked pad. This is to decrease the chance of a bacterial invasion and to prevent the tissues from drying out. We want these tissues to stay moist so they remain viable. We want to monitor the patient's vitals and oxygen saturation. We'll start an IV. If the patient does not have an IV, we'll put them on a strict NPO status. Provide the patient with support and the family with support until the action has been determined. To prevent evisceration, we will want to use the use of an abdominal binder to prevent that physical stress from happening and causing the wound dehiscence or evisceration. Lastly, we're going to discuss drains. What is the purpose of a drain? A drain is inserted into the body cavity to remove blood, serum, lymph, and other fluids that accumulate in the wound bed after a procedure. This then relieves pressure, increases perfusion, and promotes healing. It also decreases pain. These drains can be left in place typically for 24 hours to 7 days. It really just depends on the incision, the operation, the wound space, and the physician's preference. There are multiple different kinds of drains, but we are going to discuss 2 different kinds in this unit. The first kind being an active drain. Active drains I have also seen referred to as a simple drain in practice, but your textbook does refer to them as an active drain, so we will discuss them as an active drain here. So an active drain uses the use of a vacuum to evacuate the fluid from the internal canal. They're typically sutured in place, so they do not fall out. There are 3 different kinds of active drains that are commonly seen: a hemovac, which is this kind of container. We have a Jackson Pratt or a Blake drain. They both look very similar externally, they just look a little bit differently internally. They are both a closed system and they are self-suctioning. So there is a tube that runs into the body canal and it does have multiple little holes in which the fluid can go into. Both of these canisters, dependent on the kind of drain that is used, will then be compressed and closed, which then causes a vacuum-like seal, which then allows the fluid to go through the tube and up and settle into the drainage system. The next type of drain we have is a passive drain. So these are typically called a Penrose drain, and they're not used very much anymore. They create an open passage from the internal body canal to the external canal, and these would be covered with a dressing. So these are used on wounds or areas that we are expecting very little drainage from. They do have a higher risk of infection as there is an open passageway from outside to inside the patient's body. As a nurse, what do we need to do if our patient has a drain? First off, we need to know the type of drain that they have and the amount of drains that the patient has. They may have more than one. We need to know where that drain is placed, and we need to know where the tip is inserted to. This all affects the kind of drainage that we are going to see coming out of that drain. So typically, we're going to see some serosanguinous, sanguinous, or serous drainage. Sometimes we might even see like a bile-type fluid drainage. We're going to want to note the amount of drainage that is coming out of this drain. We're going to want to note if there is an increase in the drainage amount or change in the drainage consistency, as this may indicate a hemorrhage and require further intervention. If we are suspecting a hemorrhage, we are to monitor vitals and report to the charge nurse or to the physician. Any significant decrease in drainage could mean that there is a blockage in that drainage tube, which is also something that we need to report to the physician. Historically, we were taught to milk the drains if there was a blockage, which just means milking the tube or putting pressure on that tube and massaging it. Current research has suggested that that is not appropriate anymore, that it actually can cause further trauma. But it is something that we do sometimes see in practice. So just noting that if you are asked to milk a drain, just stand up for yourself or just refer to the textbook and say that that is no longer the most appropriate resource or the most appropriate way to deal with a blockage of a drain. So the typical amount of drainage that we do see is 100 to 150 mils in a 24-hour period, and it should be in decreasing amounts every day. We're also going to want to monitor and assess the condition of the collecting apparatus. So we want to make sure that that collecting apparatus stays intact, that we want to make sure that it is clean and that it does not increase the risk of patient's infection. The presence of drains is not without the complications. So typically drains can be quite painful as it is a foreign body that is inserted into the canal or inserted into a patient. So this can be quite painful for a patient. It does provide a pathway for infection. It can cause some mechanical damage to the tissues. As previously stated, it is a foreign body, so your body does reject it and it can be quite painful. It cannot drain. As I previously stated, milking of a drain was historically taught, but it is no longer an appropriate teaching or an appropriate method of dealing with a non-draining drain. The most appropriate way to deal with a drain that is no longer draining or that may be blocked is reinserting a new drain, and that is something that a physician or a surgeon will need to do. Or there may be some excessive drainage, which can lead to something called hemorrhage. Cleaning of a drain site is a nursing responsibility. So there's a higher risk of contamination when we do clean a drain site, just as of the mechanism of the drain itself. It is considered to be the dirtiest site when it's combined with an incision. Oftentimes you will see an incision and on the end there will be a drain site. So it is considered to be the dirtiest site. So when we are cleaning incisions, we always clean from the cleanest to the dirtiest So if it is the dirtiest site, we do clean it last. We clean the incision first. And we cleanse in a circular motion. So again, similar to cleaning an incision, we use one cotton swab per swipe. So we're going to need multiple cotton swabs, as we're going to have to lift this swab up multiple times in order to get that circular motion in. This is a skill that you are going to practice in lab. It's also a nursing responsibility to empty the drains. Typically, drains are emptied 3 times a day or twice a day. So to empty a drain, you need to put on some gloves. You need to assess the fluid that is in the drain. And then you need to obtain an appropriate measuring device. So a measuring device that is going to hold the appropriate amount of fluid that is in that drain. So here in this picture, it is shown with a medicine cup. So a medicine cup would be appropriate if the drainage in the bulb or in the drainage tube was less than 20 mils. But if you have a drainage amount of greater than 20 mils, you won't want to use a medicine cup. You'll want to grab a larger container. So then we release the port. So there's a port on the top of the bulbs or the drainage canisters. And then we'll just squeeze out any contents inside into that measuring device. From there, we'll then again assess that fluid. We'll look for the color, the consistency, the odor, and the amount of that fluid. And then we'll set it to the side. At that point, we will then clean that port that we just poured this liquid or the fluid out of with an alcohol swab or a chlorhexidine swab, and then we will close it. Before we close it, we will ensure that there is active suctioning. So we will squeeze the bulb together to activate that vacuum seal. We will then discard of any fluid contents in the appropriate manner, and we will document the amount, the odor, the color, and the clarity of the fluid that we had drained. Removing a drain is also a nursing responsibilities, but they are done per doctor's orders. So this is not something that a nurse can decide or assess to do on their own. It is something that a physician needs to order. We need to assess for the patient's pain and possibly administer an analgesic 30 to 45 minutes before. Removal of a drain can be quite uncomfortable for a patient, but it is only for a short period of time. We need to assess the drainage amount in the last 12 to 24 hours. If this patient is actively having a lot of drain coming out of their drain, we're going to double check, or we're going to question maybe removing this drain. But if this drainage amount has significantly decreased over the past 24-48 hours, we're going to consider it maybe being appropriate. And we're going to have to understand the removal or the reasoning for the removal of this drain as well. We're going to gather supplies for a dressing change and the drainage removal, explain to the patient what we're going to do and how it's going to happen. We're going to cleanse the wound and the drain site. So remember, we're cleaning the wound first and the drain site last. We're going to release that vacuum seal. We're going to cut the suture. As I previously mentioned, these are all sutured into place. So just using some suture cutters and cutting that suture. And then in one steady motion, we're going to pull that drain out. We're going to pull this drain out by wrapping the drain around our hand. Typically, these drains are in the body a lot more than what we would expect. Typically, they're 12 inches to 18 inches inside the body, so they are significant in length. After we pull out the tubing that is inside the body, we're going to assess the site that we just removed it from. We're going to do a wound assessment to that site, and we're going to assess the tip of the drain that we just removed. We're going to want to take a look to see if it's intact, or does it look like it has been sheared or a piece has been broken off inside. If it does, then we need to report this to the physician and get some further follow-up or assessment. We're going to apply a dressing to that drain site. Sometimes these drain sites leave a significant hole or a wound to the patient, at which point we may need to apply a steri strip to cover that wound. And then we are going to document. And that is the end of Unit 2. So please, if you have any questions, feel free to email me as the email provided on Moodle. If not, please come to our online sessions to ask any more questions. Thank you.